Ladies and gentlemen, thank you for standing by, and welcome to the Go to the Source Kentucky BRFSS webinar. During the presentation, all participants will be in a listen-only mode. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Tuesday, April 30th, 2013. It is now my pleasure to turn the conference over to Sarah Walsh. Please go ahead.
Thank you, Tina. You did so much better with the BRFSS acronym than I usually do. So welcome, everyone. I'm Sarah Walsh with the Foundation for Healthy Kentucky. I will warn you now, if you are not here for the call on Kentucky Behavioral Risk Factor Surveillance System, then you're in the wrong place. And if you are in the right place for the discussion of the Kentucky Behavioral Risk Factor Surveillance System, I am going to stop saying that very, very long acronym and start calling it BRFSS. And I apologize, but, well, I didn't name the survey, so I'm just going to call it something short. If you were here last week, thank you so much for coming back. If this is your first Go to the Source webinar, I wanted to take just a minute to tell you about the webinar series before we get started and I turn the call over to Sarah Jeannie. For the past few years, the Foundation has offered webinars and in-person workshops to support the work of emerging and established health coalitions doing the important work of fostering change in Kentucky. And we still do that. We're going to keep doing that. But this year, we also wanted to expand that effort to specifically address the needs of data users, because those are my people. So whether you're a researcher, if you're an epidemiologist, a grant writer for a nonprofit, if you were tasked as the MAP coordinator at your health department, if you're working through a community benefit plan in your local hospital, whoever you are, we're delighted you're on this call, and if you're serious about health data, then that's what this webinar series was created for. And I always like to start with a completely shameless plug for Kentucky Health Facts. Kentucky Health Facts is a website sponsored by the Foundation that was launched in 2008. It's designed to provide anyone, us data wonks and novice users alike, with an overview of the health needs and resources for each community in our state. But sometimes you need to dig deeper than the information that's available on that website. Kentucky Health Facts was designed to be the overview, but sometimes you have to go back to the original sources of information and learn more. And that's why we created this series, to introduce you to some of the key health data tools and resources in the state and the people behind those tools, so you know where to turn for help when you need it. What we're doing is, before we kind of get further into today's talk, I wanted to just show you where we were in the series. And if you've not signed up yet, you can register for the other webinars at our website, which is healthy-ky.org. Last week, Janae Grandmont gave us an introduction to the mapping functions and other capabilities on Health Landscape. And if you missed that call, the webinar is archived on the Foundation's website, so you could go back and listen to it. Or if you wanted to learn more, I know that Health Landscape offers their own periodic trainings and intensive full-day workshops. So if you kind of walked away saying, man, Health Landscape does a lot, there is help where you can get a little bit more intensive one-on-one training if that's something that appeals to you. But still to come in May, we're going to hear from Mike Childress about the Kentucky Medicaid Pharmaceutical Utilization Guide, and Jennifer Chabinsky and Mike Carosa are going to talk about the Kentucky Health Issues Poll and OASIS, which is an online statistical analysis tool where you can access not only the Kentucky Health Issues Poll, but a number of public use data sets if you wanted to do research and custom analysis and that sort of thing. Later on in June, Michael Price is going to tell us more about the Kentucky State Data Center and really a lot of Census Bureau products and population estimates and all the demographic information you really need. Then you're going to be stuck with me in July to learn about our Kentucky Parent Survey that we sponsored here at the Foundation. And Amy Swan is going to show off the brand new, not even yet released Kids Count Data Center 2.0, which will launch later this summer with all kinds. The original data center is online now, and it has all sorts of health and economic and well-being indicators for children around our state, so that's a great resource. And because we are data people, I have to shamelessly say, please watch your email. You are going to get a message from us tomorrow linking you to an evaluation for this training. This is the first time we've offered Go to the Source, so we need our data. We can't function without data. So please let us know what you thought of today's talk, what we should be doing in the future, because we really want to make this series useful for you as a data user. But having fully gotten through my spiel, I wanted to dive into today's webinar. We're lucky to have Dr. Sarajini Kanotra with us. She is the director of the Kentucky Behavioral Risk Factor Surveillance System. Okay, that's the last time I say all that. She's the director of Kentucky BRFSS, and she holds a PhD in microbiology from the Indian Agricultural Research Institute and a master's in public health from Emory University. And on a personal note, I will just say that Sarajini has been really wonderful to work with, and the Kentucky BRFSS program is a key partner for the Foundation for a Healthy Kentucky. In order to make BRFSS data at the county level available throughout the Commonwealth, Kentucky BRFSS and the Cabinet for Health and Family Services sponsored the initial development of a methodology to produce high-quality data for small geographies. It is really hard to get local health information, and we know that's what everyone craves from this data set. So they worked with some researchers to figure out a way to make that happen. And in turn, we've funded those researchers at the University of Kentucky to replicate that analysis on an annual basis. And that really forms the backbone for Kentucky Health Facts. So now that I've gotten my second Kentucky Health Facts shameless plug in, I will let Sarajini take it from here.
Thank you, Sarah. Thank you for this wonderful introduction. And I'm not going to say a behavioral risk factor surveillance system myself. I don't know who named it, but it is a long name. And that surveillance part, you know, puts people off. And then it adds BRFSS, you know, the behavioral risk. So today we'll be talking about BRFSS. And the first thing that comes to our mind, because people, when you say BRFSS, you can spell it as B-U-R-F-S-S. So, but it is BRFSS. And what is BRFSS? The first thing I would like to plug in is that it is the largest continuously conducted health service system in the world. I hope everyone knows it now. And it pretty much is the state-based system of health surveys, which is done in collaboration with CDC. And this health service system looks at individual level risk factors associated with the leading causes of death among adults. And some of the topics that include health risk behaviors, clinical preventive services, and healthcare access and utilization practices. So where does this data come from? As we all say in Kentucky, the data comes from you all. It comes from adult residents in Kentucky. And who uses this data? Pretty much everyone uses this data. I would encourage the audience to check the data sources in America's health rankings, county health rankings, and as Sarah told, Kentucky Health Facts, Healthy People 2010, and now Healthy People 2020. So pretty much we have an entire spectrum of people who use this data on a regular basis, even elementary and middle school students. So coming to what we call it just not BRFSS, but we call it as KY-BRFSS. So it is our BRFSS. So what is the actual data collection process? And I'm glad that Sarah gave me this opportunity to talk about how this data is collected, because on a regular basis to people, since it's just a health survey, people do not realize what goes into collection of this data. So CDC does provide a standardized methodology for the collection and analysis of data. So in all states, all 50 states and territories collect BRFSS data, and they use the core questionnaire. And this, what this does, it allows state-to-state comparisons, and it allows local-to-local comparisons too. So the mode of data collection initially, the main mode of data collection has always been landline phone. And BRFSS started in 1984, and Kentucky joined in 1985. And recently, BRFSS has started collecting data through cell phone. In Kentucky, we started it in 2009. We also have tried another phase, that's the mail survey to non-respondents. This is in pilot phase, both at CDC and also in Kentucky. We have also done the web-based survey to non-respondents and face-to-face interviewing. This was done mainly only piloted in Kentucky, and it was done to collect data from Hispanic residents in Kentucky. So what is the process? If you look at the process, the main way of collection of data is a monthly telephone sample is received from CDC by every state. It has a household sample design, and we do random digit tallying for landline phones. So, and we have random selection of adults 18 and older, and we conduct interviews. So some states, only 11 states in the nation do collect data in-house. Otherwise, data is collected through contractors, and our contractor in Kentucky is University of Kentucky Surveys Research Center. So when you receive calls for BRFSS, they are coming from the University of Kentucky Survey Research Center. And they enter data into CAT-I, and that is the computer-assisted telephone interviewing system. And this data is edited before it is moved over to CDC. I will describe a little bit further. This is just like in a snapshot I told what is the process. So going digging in a little deeper, especially for our data wonks, I would like to explain that the sample design is very critical for BRFSS. As we see in a telephone service system, each a sample record is one telephone number in the list of all telephone numbers selected for dialing. And the sample records must be justifiable as probability sample of all households with telephones in the state. So the sample design specifies a list-assisted random digit dial sample of telephone-equipped households in Kentucky. So anyone who has a telephone, whether it is a listed or an unlisted number, makes the landline sampling frame. So digging a little bit deeper into what is the design that is followed by BRFSS, it has a complex, stratified, disproportionate random selection of samples. So which means that all population elements are classified into strata, and separate samples are drawn from each stratum. And why is this done? This is mainly done to reduce sample variance, and also if we can get separate estimates can be obtained from strata. And in addition, we can do oversampling. So what BRFSS follows is disproportionate sampling design. And explaining it in this little further, the telephone numbers are divided into two strata, and these are the high density strata and the medium density strata. And the high density and the medium density strata contain telephone numbers that are expected to belong mostly to households. And whether a telephone number goes into a high density or a medium density stratum is determined by the number of listed household numbers in its 100 block. And as you can see on the slide, what does a 100 block mean? It's a list of 100 numbers and where the area code is similar, the prefix is similar, and the first two numbers of the telephone are same. And the last two numbers, are a variation from 0 to 9. The last two numbers are different. So from each 100 block, you have 100 blocks of high density and medium density strata, and from these two strata, we get the sample disproportionately. So if you someone wants to look at it, how the structure of this landline sampling frame is. And so, as I said earlier, the disproportionate stratified sampling, we have the listed are in the high density stratum, and listed plus block telephone numbers are in the high density stratum, and the medium density stratum consists of not listed and 1 plus block numbers. And high density strata are sampled at the highest rate. So that is why we call disproportionate sampling. And I'll give you, and in addition to the strata, these two strata, we also have geographic strata that are specific to Kentucky. In Kentucky, we have the 15 area development regions, and these we stratify by these area development regions. And there was a special project that BRFSS collaborated with the Global Metro Health Department, and their CPPW project, which is also known as the Communities Putting Prevention to Work project, BRFSS helped in doing their pre and post survey, that is pre-intervention and post-intervention survey, and in that the community wanted the sampling to be designed to be having samples from 12 neighborhoods in the western Louisville region, and they wanted to oversample Hispanic population and the rest of Louisville. So we actually had, in addition to having the high density strata and a medium density strata, we overlaid with the geographic strata of these three strata. So this makes it a very complex design to do surveillance. And as I briefly mentioned earlier, that the Kentucky was the only state in the nation that has done face-to-face interviewing, and this was mainly to get information for Hispanic population. So for this, we looked at the map of Kentucky and looked at where in Kentucky we had a population of more than 3% Hispanics in Kentucky, and we selected 12 counties in Kentucky from where we did which we used as our sites where we conducted the face-to-face interviews. And recently I did say that BRFSS has started doing cell phone surveys too. And for the cell phone, the sampling frame is different. And why is this? Mainly because the cell phones are not linked to households, which makes it a little challenging to use the cell phone sampling frames. So the entire state is selected as entire frame for the cell phones. And currently, they are not, as I said, they are not linked to any lower levels of geography. The switch centers serve as the unit of geography for the cell phone. So here we are using the 1000 series blocks. And that, as I briefly said earlier, and I'm going back to that slide, in this slide, you can see that we had the last line shows the 1000 series blocks where the last three numbers of the cell phone are used as the 1000 series blocks. So in essence, BRFSS is following a dual frame to do the sample design. So our target population for the landline survey is adults aged 18 and older, and those that are residing in a private residence within the state being sampled. And for a cell phone survey, it's adults aged 18 and older living in households who do not have a working cell phone, who have a working cell phone and do not have a landline phone. So this is essential that these respondents do not have a landline cell phone. So in Kentucky, what's the sample size? And this is only for 2013, I'm telling. We have more than 10,550 completed interviews. So definitely we do landline sample of 7,500 completes. As I said that we have 15 area development districts. So each area development district, we essentially have at least 500 completes. And we oversample for African American population and have at least 800 completes. For cell phones, we have increased our cell phone percentage to 30% of the original landline. So this year, we are planning to do 2250 completes. And on an average, our contractor makes at least 30,000 attempted calls per month to respondents. So coming to the respondent selection. So when the interviewer calls a respondent, if a single adult responds to the phone, that person is selected for doing the interview. But if there are multiple adults living in that household, they are asked that who has the most recent birthday, and that person is selected to complete the interview. And we exclude the phone numbers if they are belonging to a business, institution, group quarters, and if the residence does not have anyone that is more than 18 years of age and has both landline and cell phones. So what do we do when we have no contacts? If a call to a sample telephone number is not answered, busy, reached an answering machine, the number is repeatedly called at different times, during daytime and evening hours, on different days of the week, in a computer-monitored fashion. And so at least 15 call attempts are made before we say that this number will not be called again. And we do have respondents getting annoyed. And so with the exception of really hard refusals, that is if someone is verbally abusive and says, take me off your list and do not call again. We do have some of those. We still call them eligible persons who initially refuse to be interviewed will be contacted at least one additional time to give them an opportunity to complete the interview. And this is the second contact is conducted by interviewers who are very experienced in and trained in converting refusals. And I really do appreciate all those interviewers because I have the opportunity to monitor these interviews remotely. So as per our contractor standards, all hard refusals are coded as 1225 because no one will be called on Christmas Day. So the callbacks this means that if they are coded as 1225, that means that these callbacks are to be brought to a supervisor's attention. And this is a screenshot showing how a computer-assisted telephone interviewing looks like. The CAT-I, it manages the selection of telephone numbers and displays a BRFSS questionnaire on a computer screen during each interview. So the interviewer has the capability of read the questions off the screen and also enter the answers of the respondents. So this shows pretty much a flow chart of what each interviewer is trained to do. So if they dial a number, if there is no answer, the number is dialed 15 times. If it's a residence, then again, they go ahead and determine the eligibility of the household. So we do have to sometimes, leave a phone number, deselect a phone just because we do not find any eligible person. So it's not just that BRFSS is making random calls and getting answers from anyone who answers the phone. So if it's a non-residence or a non-working number, the calls are stopped. And so this is how BRFSS interviewers follow the protocol and call the people to get the completed response. And for cell phone respondents, this is a different beast in itself. And this is a very expensive process even for BRFSS because we cannot randomly digit dial is not allowed for cell phones. So to determine the study eligibility, the person answering the telephone is asked whether they have been reached on a cellular telephone, they are aged 18 or older, live in a private residence, and reside in the state. And whether they also have a landline telephone in their home that is connected to outside telephone lines through a cable cord or is used for making or receiving calls. Sometimes people have Google phones or Vonage. So we do screen for this when we are asking a cell phone respondent. The cell phone respondent is also asked that if they are not driving or not. If they are driving, then the interviewer will disconnect and will not continue the interview. So coming to the questionnaire design. Again, this is a complex sample design, and it leads to a complex survey design. The questionnaire consists of 3 portions, like mainly 3, a core question, and it has optional modules and state-added questions. So the core is a standard set of questions which is asked by all states. We have a fixed core section, a rotating core section that we have topics that are asked, specific topics that are asked on odd and even years. Then we have emerging cores, questions such as the H1N1, and now recently we may be asking about H7N9 if we see any outbreak in the United States, because the BRFSS is preparing because we have seen that outbreak in China, so we are preparing just in case we may need to ask questions and add questions in the emerging core. And optional modules, these are a set of questions on specific topics that states elect. So this is where the state can elect. So this is where we have specific questions that can be added by each, specific to each state, where state added questions and optional modules. So this questionnaire could be a single survey, or if we want to add more questions, it could be a split design. That means it can have two arms or 3 arms. But when we have more than one single survey, we have a split design. That means that the core will be, again, still asked. It's mandatory that we have to ask all participants. But when we have split design, if it's like 2 arms, that means that if we have 5,000 respondents, 2,000 respondents will be asked arm A, and another 2,500 respondents will be asked the second split, arm B. So some of the fixed core sections, these are the fixed core sections. The alcohol consumption, chronic health screening question. In earlier years, and before 2011, if I'm not mistaken, we had asked like questions about 13 health conditions like diabetes, arthritis, asthma. They were asked separately. But now this has all been collapsed into a single question, screening question, where around 13 conditions are asked. So we are asked, the interviewer is asking, has a doctor, nurse, or other healthcare professional ever told that you had arthritis, COPD, asthma, myocardial infarction, angina, stroke? So all of these questions are, this is a change that has occurred in 2011. And these are the rotating core questions. Odd years we are asking, like this year we are asking about fruits and vegetable intake, hypertension awareness, cholesterol awareness, arthritis burden, physical activity. And in even years we talk about women's health, prostate screening, colorectal cancer screening, oral health, falls. So these are the questions that we are asking in the even years. And there are a lot of optional modules that are made available through CDC to the states for adding in their questionnaire. So we pretty much have been adding diabetes and prediabetes on an annual basis, and tobacco use. But this selection is a process. There's a process of selection of these optional modules. It's not just my selection. We have a data users committee, and so they provide us input on the addition or not addition of these questions or optional modules. And some examples of state-added questions, and we know we are the tobacco state, so we do have asked a lot of state-added questions about tobacco, bidi, cigar, pipe, and we have recently asked questions about Alzheimer's disease, occupational dermatitis, family planning, folic acid. So these are some examples of state-added questions that are asked in BRFSS. Now, coming to my next section, there have been some recent changes in the BRFSS protocol, and this was done in 2011. CDC made 2 changes in their methodology, and these 2 changes were making survey calls to cell phone numbers and adopting an advanced weighting method. And why add cell phone numbers? And we know that we are doing a probability sample of the population. We are not calling all 4 million people living in Kentucky. And so what we were doing, we were calling just landline phones. But it was realized by CDC that, the number of cell phone-only households increased by more than 700% during 2003 to 2009. And this was especially stronger in younger age groups and in certain racial and ethnic minority groups. So even with the best sampling design, we were leaving out this population. So if we look at the, diagrammatically, we can see that if we can see here, that beginning from 2003, we have the cell phone only household has increased. And we are also seeing that it is increasing in the younger age groups. So who are we leaving here? We are leaving here unrelated roommates. So renters, 18 to 24-year-olds, 25 to 29 years. So we were not including them in our samples. So this is why this was one of the major reasons that CDC made this change in the protocol. And once we add cell phone into the system, what happens is, as I said, that cell phones are not linked to a geography. So that makes it harder for us to do the weighting process. So since we are having a dual frame, so CDC utilized a new method of weighting. So what exactly is weighting, and why do we do weighting? So we do weighting mainly to make inferences about the population from the sample data and produce population-level estimates from sample survey data. And this is mainly to reduce possible bias and reduce variance, which determine the goodness of the estimates. So it's a process. This process is used to make sure that the data is comparable to that of the overall population. Previous to 2011, CDC used the post-stratification method. That is one of the methods used for weighting, post-stratification method. And that method of weighting forces the proportion of a given demographic subgroup in the sample to match the proportion of that subgroup in this population. In lay terms, for example, females ages 18 to 24 of age represent 5% of the survey sample. So only 5% in the sample, the completed surveys, only 5% were women ages 18 to 24. But in the census, we see that women ages 18 to 24 make up 10% of the population. So what post-stratification will do, it will give a higher weight to these females, so to make them comparable in that data. So that means this assigned weight for each respondent in the database indicates how much each respondent will count in statistical procedures. In unweighted data sets, each respondent represents one person in the population, but in weighted data sets, one respondent may represent 200 individuals in the populations. So it is very critical when you answer. So you may be representing maybe 500 persons in individuals in the population. So it's critical. What you answer is very critical to BRFSS. So this new method is an advanced methodology of post-stratification. What it does is allows the incorporation of cell phone survey data and introduction of additional demographic characteristics. And as I said earlier, it matches sample distributions to known demographic characteristics of population, and increases the goodness of the estimates. That means it reduces the non-response bias and reduces errors within estimates. It's also known as iterative proportional fitting. So, and I'm not going into too much detail, but it now allows, earlier we could only weigh by using the standard age, gender, and race variables, but now this raking allows us to, it helps us make the margins crisper, and that is how I can explain in a very lay terms is that, just like when you are raking leaves and bringing it to making a pile. So these variables help in making the margins crisper. So at least 75 iterations are done for each variable. Like when we are weighting the population for age by gender, the computer will do it for 75 iterations before it will go to the next variable. So what are the effects? So making these changes definitely had an impact on our BRFSS data. And what CDC predicted was it will affect the size and the magnitude of effect will change, then this will change. So, but it will vary from state to state because each state, all the states they will have a different percentage of cell phones and landlines in their state. And what CDC had anticipated was there would be small increases in the prevalence of tobacco use, obesity, binge drinking, HIV, asthma, and health status. So when we received our 2011 data, we looked at how did it what effect these changes had on our data. And what CDC definitely recommends, and I would also chime in for that recommendation, is that for any kind of comparisons, we should not compare 2010 data with 2011 data. When I am doing comparison here is mainly to see what are the changes in the size and direction of the effects. What we found when we looked at the 2010 data versus 2011 data, we saw an increase in the 18 to 34-year-old respondents. We saw an increase in male population. We saw an increase in Hispanic respondents. We saw an increase in the African American respondents, those that did not graduate high school, and those with an income lower than $15,000. So when we look at these graphs, we can, if you see, it shows, so basically this is good news. In here we see that Kentucky became a little slimmer, like, lower rates of obesity. We saw minus 1.4, like if the rate was 21.4 in 2010 for obesity, it was, you can subtract, like it was 20% in 2011. And so very slight increases were seen for other chronic conditions. So basically what I'm trying to say that it did not have a major impact on the changes in the prevalence. And looking at the health status and healthcare access, we do have to remember that we have people, younger people, we have people of less education, people with less income here. So what we saw was there was an increase in the number of respondents who said that they could not afford to see a doctor. And there was a decrease in the number of respondents who said, in the prevalence of respondents who said that they did not have health care coverage. They had health care coverage. So less people had health care coverage, and less people, more people said that they could not afford to see a doctor. And in health risk behaviors, this is where we did see some major impact. We did see an increase in the current cigarette smoking. And another area that we did see was in binge drinking. So that was 4.2 prevalence percent points increase in current cigarette smoking. But what I would like to reiterate is this is not an actual increase in prevalence. It's mainly because the way the methodology, so we have more younger people here. So when we have more younger people, they tend to have higher risk behaviors. So this is why we are seeing, but we can say that authentically, like with confidence more, when we can compare 2011 raked BRFSS data with 2012 raked BRFSS data. We have actually compared some of the 2011, 2010. We did start cell phone interviewing in 2009, but our sample size for cell phone was small. So we have compared raked 2010 data with raked 2011 data. So we did see that, there's not much change, but actual changes can be seen only when we can compare apples to apples. And another place that we saw the maximum increase was when less people said that they had been tested for HIV. But a good thing was that more people said that they had ever had, there were a higher prevalence of people who said that they had pneumococcal vaccine. So how did these two changes impact Kentucky data? So as I said, that the largest changes in prevalence estimations were seen in binge drinking, which is not good in Kentucky, because what happens is for years we have seen that Kentucky ranks lower than the nation for binge drinking. But now Kentucky, we are seeing that there is an increase in the binge drinking. We are seeing an increase in cigarette smoking, increase in disability activity limitation, increase in ever had pneumonia vaccine, and lower numbers of people reported that they had been tested for HIV. And so I reiterate that please use 2011 data as baseline for tracking trends in the upcoming years. And whenever we are doing a trend data, or whenever as epidemiologists we would see, even if we are showing a trend from, say, 1999, we show a break in that graph in 2011. That will show that there were some changes, artificial changes in the methodology that is affecting the data, and not the data itself. And some here, it's almost where I'm talking about the data analysis. So since it's a complex survey system, and we weight the data, since 2011, the new weighting variable that has been used is the CPWT. Prior to 2011, it was final weight. And as I said earlier, that addition of questions to Kentucky BRFSS is a process that is where we receive input from all data users, and the decision is made by our steering committee, and the chairperson of the steering committee is the commissioner for our public health. So this is the contribution for all data users who can help us make the questionnaire Kentucky specific for areas that are specific for Kentucky. And anytime we have data requests, we are a team of 2 people here, and you can find information about BRFSS on our website. This is our website, and we have made our name simpler, we have made our link a little simpler. It's not as fancy as the Kentucky Health Facts, but yes, you can find information about, we have the annual reports, but we are still working on adding more annual reports. But what is new on our website is that we have the Kentucky Area Development District profiles, and as soon as we should be receiving the 2012 BRFSS data soon, and within a month of receiving our 2012 data, we would be posting the 2012 Area Development District profiles on our website. And in case you have any requests, we have links to forms on this website, or you can email me or Seth Siama to complete any data request. And we also can go on the CDC website. for normal, like if we are not wanting any specific analysis. And so all of the information about Kentucky is also available on the CDC website. And they have made some good changes on the website. And definitely if we want to do county-level data, if we want to find county-level data, that is done by our partner, Kentucky Health Facts, and you can find information about county-level data on the Kentucky Health Facts or county health rankings. And some of the examples of some of the reports that have been published using BRFSS data, one of them is the Kentucky Area Development District Profiles, and you can also see the Place Matters report that was developed by the Foundation and using the African American, we had done oversampling for African American population. Then asthma program created their asthma surveillance report, and tobacco program released their tobacco use in Kentucky using BRFSS data. Some of the, again, some important websites are listed here. The CDC, BRFSS for the cabinet, and we can also go to our website through the Kentucky Health Facts. So here, this is my contact information. I have listed both mine and Seth Yama, who's the BRFSS epidemiologist, and I would like to acknowledge his contribution for this presentation. So this is where, Sarah, this is the end of my presentation. I would like to take any questions. Thank you.
We'll give folks a minute to, if you have questions or things that you thought of while Sarah Jeannie was talking, please go ahead and enter those in the chat box, and we'll get to them kind of in order. But I wanted to start, we had one question about the weighting variable. You mentioned there was a new weighting variable since 2011 called LLCPWT. Do you know what that stands for? What's the secret code? It's
landline cell phone. Basically, I'm just telling because BRFSS has at least 300 to 400 variables, and if we are analyzing this data, we need to know what variable we need to use. So if we do just descriptive analysis without using this variable, it will give us just unweighted prevalence. But if we want to have accurate prevalence, we need to use this variable. Does that answer your question?
It does. Landline cell phone weight. That makes
yes.
That makes sense now that you've said it. I'm going to go ahead and speak for everyone and say, I bet we're wondering about 2012 data. You shared the differences between 2010 and the new cell sample in 2011. What is the timeline, do you think, for 2012 results coming out?
I was told by CDC that we should be getting by the end of, I should be getting an email today. So
wow.
I haven't yet. So we should be having something on my downloads website. So we should be getting that data within a week, definitely. That's what I was told.
So at that time, will the state-level information be on the CDC's website?
No, that will be posted later, but I will have the data. So I will have the data. If anyone needs that data set, they are more than welcome to get it, request that data.
Okay, so we can get the data set from you, and then later this year we should look for the updated ad district report?
Yes, within a month. That's my promise to all the data users. Because that is the data that is not available on CDC's website.
What about zip code specific data? We had a question about Jefferson County, but is the BRFSS data set coded by zip code?
Yes, we can separate it by zip code.
So that kind of, if there's enough respondents, that level analysis is possible.
Yeah, what is important here to understand is that although we have a big sample size, but we should remember this is still a sample. So we may not have in a zip code enough respondents, and by enough, CDC recommends at least 50 respondents. So it will be very difficult to have 50 respondents in a zip code in a county, let alone in a zip code. So like big counties such as Jefferson, yes, we do have a big sample size, because I know for Jefferson County, because we also do oversampling, we have a sample size as large as 2,000. But in very rural counties, counties, we do not have a big samples, like a number of respondents, and that is where Foundation has been very critical in helping us do the analysis. UK has been doing the analysis for having county-level data available. And even then, they had to collapse a number of years and also collapse a number of counties, similar counties, to provide county-level data. Even when we see county-level data from BRFSS on the county health rankings, what is important for us to see when we go to the source, and this is for all the data nerds out there, we need to see how many years have been collapsed to provide data. It's like I know for the most recent 2013 data, they call it 2013, but the data is for BRFSS that they have used is from 2005 to 2011.
Are you speaking about county health rankings?
Yes. And they have used 2011 data because, again, the BRFSS branch in CDC has given them data that is that has been weighted differently.
Okay. So if someone wanted a custom report for their county, their zip code, their service area, how would they have that? How would that go about? Would they request you and Seth help them with that, or can you provide the data set publicly? What should someone do if they need special analysis?
If they can send us the request, and we can definitely look into the data. And when we release that data, if we have very, very few respondents, my recommendation is not to release that data. Because what happens, especially when you say zip code level, then we are giving wrong information to people. Sometimes when we have a very low number of people responding, we can have a very high prevalence rate. So it may seem a bigger problem than what it is, or it may also seem a smaller. So it can be both ways. So if the sample size is less than 50, I'm always hesitant to release that data. But yes, we can definitely look into that. And it depends on when they are giving us the data request, we can help them, find something that is that may be helpful to them.
Sure. I'll give folks a few more minutes. If you have questions, you can chat them in. I'm going to go ahead and, on behalf of cell phone users around the state, thank you for including that sample, because I know that I personally do not have a landline telephone. So
yes,
I'm excited to see me represented in this state, although I've not gotten a BRFSS call yet.
But they are expensive, throughout the nation. If you know how much we pay for each cell phone, it ranges from $75 to as much as $175 per completed survey. So that's the reason you do not see a high number. But we are hoping that, as the time that we will be able to increase, because we have increased our cell phone percentage to 30%, because that is the latest percentage I knew is in Kentucky, that at least 30% of the respondents in Kentucky have 100% cell phones.
That's great. And a question about how do you get the unlisted phone numbers? If somebody's not listed, is it a random digit?
Yeah, this is something that each state does not get, but it is something that CDC can procure because they are working with MSG, full form is Marketing Service Groups, and they are the ones they provide the unlisted phone numbers to CDC, and CDC will provide those numbers to us.
Okay.
But the main thing is that we do not have any access to any confidential information other than the phone numbers.
And that is probably important too for the folks that we
I know, but otherwise we would be missing that population again. So we do get listed as well as unlisted numbers in the sample.
Okay. Can you say more about the face-to-face interviews? Because that was kind of cool that Kentucky is the one in charge of that pilot and the only state where that's going on right now.
Yeah, this was more my baby because I had tried, as I said, we were oversampling for Hispanic population in the Louisville CPPW project, and I oversampled like 200 completes. We wanted at least 200 completes, and what I got was only 20 completes.
That is
so
not
that really did bother me because I had, you know. So what I did was I started my conversation with the Office of Minority Health and with CDC, and Office of Minority Health was able to put me in touch with AHEC promotoras, the lay health workers. And what we did then was I talked with CDC to do how to do the sample design, and we used those promotoras, we trained those promotoras to actually to do the BRFSS. We used the 2012 BRFSS hard copy survey in Spanish, and these promotoras were recruited, these Hispanic respondents, and were able to do face-to-face interviews with them.
Well, we've got a good research wonk question. Did you have an IRB approval for that, specifically for the face-to-face interviews, or is the whole?
Yes. Before and IRB, yes, we have done that. And also, one of the things for BRFSS use is that we are IRB exempt too, just so that everyone knows. CDC has this BRFSS as IRB exempt, but when we have such research projects, we do IRB just for the protection. And even the UK SRC, anytime there's a new project and anytime just like when we do the asthma callback surveys, because we get the actual name of the person, we do go through an IRB process.
That makes sense. So and then the promotoras walk them through?
Yeah, they also had a consent.
Okay.
Yes, they did have a consent before they asked the person to complete the interview.
That's pretty cool.
And I can share the survey with anyone who's interested in looking at that survey. It's the same BRFSS, it's some minute changes.
I'm nodding. That's cool, and I hope we'll be able to share those results
soon. We're working on it. We should be able to share these results soon.
Okay, and then a general request about sample surveys. I know I have gone to the CDC's website to get the core, and then it lists all the optional modules, but what's the best way to get a sample of the survey instrument?
CDC does have this, and I don't know. You can go on to CDC survey. If not, you can always email me and we can provide you. And otherwise, what we can do is we can put the surveys, questionnaires on our website. So that would be that's where people can get the core surveys.
That might be nice, because I know whenever we're designing surveys here at the Foundation, we always try to use question language that has been validated before, and BRFSS is a really good source of that. So if you ever want to ask a question, I shamelessly steal them.
Yeah, no, I do too, because that's the best way, because anytime we have the state-added questions, what we say is that we cannot add any question that has not been validated before. So it has to be used and validated before it can be added as a state-added question in our Kentucky BRFSS.
Great. Well, if there's no more questions coming in, I'm just, on behalf of all the folks whose lines are muted right now, Sarah Jeannie, thank you so much for telling us more about the survey. And I hope that we'll see everyone back here for the next Go to the Source webinar. This has been great. Thank you.
Thank you.
And Tina, I think we've run out of things to say, so you can stop the recording.
My pleasure, ladies and gentlemen. That does conclude the webinar for today. We thank you for your participation and ask that you please disconnect all lines.
Thank you.